Dear colleagues, today we present to you a case of esophageal atresia. Esophageal atresia is a condition in which the connection between the proximal and distal segments of the esophagus is absent due to the lack of development of the intermediate segment, often secondary to ischemia during organogenesis. The incidence ranges from 1 in 2,500 to 1 in 4,000 live births. So it is a fairly common condition and is associated with a high risk of aneuploidies as well as a high syndromic risk, as we will see later. There are 5 types of esophageal atresia classified according to the Gross classification, distinguished based on the anatomy of the defect and the location of the fistula with the trachea. In type A, there is no fistula, and this is the rarest scenario. In fact, in the vast majority of cases, in more than 90% of cases, a fistula is present. Through this fistula, amniotic fluid can pass, which at least partially distends the stomach. In these cases where a fistula is present, the ultrasound diagnosis of atresia with a tracheoesophageal fistula becomes impossible or at least highly doubtful. In the case of type B, on the other hand, there is a fistula with the proximal esophageal segment of the esophagus. In type C, which is the most common, with the distal segment, and in type D, there is a double fistula, both with the proximal and the distal segment, and then there is type E, which is also quite rare, where there is a fistula present without esophageal atresia. Of the various types, type A, the one without a fistula, is definitely the easiest to identify in utero. Esophageal atresia is usually a sporadic event in most cases. We mentioned that there is a chromosomal risk. In particular, there can be an association with aneuploidy, such as trisomy 18 or trisomy 21, and it is also important to assess any associated genetic syndromes, which can be linked to genetic trisomy in about 10% of cases. And among these various conditions, we specifically have the different syndromes that are clearly listed on this particular slide. First and foremost, we always make sure to carefully rule out any potential association. VACTERL is present in about 30% of cases of esophageal atresia with or without tracheoesophageal fistula. Therefore, it is important to analyze the presence of any vertebral and vascular defects, the presence of cardiac defects, and any radial dysplasia or limb anomalies. Whereas it is indeed quite difficult, if not practically impossible, to definitively rule out an anal atresia with a prenatal ultrasound examination, as this particular condition can only be accurately assessed and confirmed at the time of birth. The specific case in question is a monochorionic diamniotic pregnancy that initially came to our clinical attention at precisely 21 weeks and 4 days for a comprehensive second trimester screening examination. The pregnancy is definitively monochorionic, as both the initial first trimester scan clearly showed a single, distinct gestational sac, and in this particular case, even though it is often quite challenging to precisely identify a single unified placenta at this relatively early stage of development, we can distinctly observe a prominent posterior placenta, and perhaps most importantly, a very thin and delicate septum, which further supports the monochorionic diagnosis. With the characteristic T sign, which is quite typical and indicative of monochorionic pregnancies, where the separating membrane between the developing fetuses is clearly visible and distinct. The two amniotic sacs does not have any chorionic tissue in between. In these images, we can see the fetus at the top right. It has a normal stomach, which is indicated by the arrow. The fetus on the left, instead, at the bottom left, has a normal bladder, which is shown in these images, but there is no filling of the stomach. In this case, the gastric bubble is absent. In some specific cases, it might be quite small in its overall size. The complete absence of the stomach bubble strongly suggests the presence of esophageal atresia without a tracheoesophageal fistula. Obviously, it is always critically important to perform a detailed ultrasound follow-up examination because the stomach could potentially fill over the course of several hours. For this crucial reason, we always make sure to explicitly specify this finding in the official report and to diligently carry out a comprehensive follow-up assessment in the following hours. Again, the failure to observe the gastric bubble is therefore the best pathognomonic clue of esophageal atresia, the presence of a small or absent stomach. As seen during follow-up, you can see the images scrolling after several hours. Again, the location of the stomach is completely empty. The total absence of the stomach suggests the absence of a tracheoesophageal fistula or, in any case, a very small stenotic connection. We can see again that after 5 hours, the location of the stomach is absent. It is possible to observe a pouch sign, a transient filling of the proximal esophagus during swallowing. However, this is not pathognomonic because it can also be seen in normal fetuses. Therefore, it should not be used as a diagnostic criterion for atresia. We see that in this case, another sign can be the presence of polyhydramnios. Polyhydramnios rarely develops before 20 weeks. And we see in this case that in this fetus there was no presence of polyhydramnios in this initial diagnostic exam. And then this particular phenomenon may very well be due to the significant fact that fetal urination is not a particularly important or crucial part of the overall amniotic fluid dynamics until approximately 20 weeks of gestation. Another ultrasound finding that is visible in up to 40% of cases is growth retardation, which is present in this case. And normally, growth retardation is primarily due to the crucial fact that the amniotic fluid is incredibly important for proper fetal growth and development, especially during the latter, more critical part of the entire pregnancy. As a result, the presence of esophageal atresia causes an overall loss of proteins in the fetus and therefore leads to growth retardation. Naturally, when this is severe, it can then affect the neonatal surgical approach for these fetuses. In our case, growth retardation was present, but with normal Doppler flow both at the level of the umbilical artery, the cerebral artery, and the venous duct, and there were no signs of twin-to-twin transfusion syndrome despite a biometric discrepancy of about 21%, as we can see from these images. Most of this significant discrepancy was primarily due to the undeniable fact that the first developing fetus was a few crucial days larger than its estimated gestational age, while conversely, the second developing fetus was a few noticeable days smaller. At the 24-hour check, the absence of the gastric bubble in the fetus on the left was confirmed, as well as the suspicion of esophageal atresia without fistula. Then, when evaluating the amniotic fluid, it was found in this case to be at the upper limit for the gestational age. As a precaution, in these cases, the fetus must always be checked repeatedly to be certain of the diagnosis. We re-examined the fetus after 5 days and the stomach was still not visible, so the location of the stomach remained empty at every observation. And this confirmed the suspicion of esophageal atresia without fistula. The amniotic fluid also remained at the upper limit for the gestational age, with a maximum pocket for the fetus on the left side, which in this case measured 74 millimeters. In conclusion, a careful ultrasound follow-up is necessary both to be certain of the diagnosis we are making, and in our case, we examined the patient multiple times to confirm the suspicion of esophageal atresia without fistula, and also to monitor over time. This is because it is important to assess the presence and severity of polyhydramnios, as well as any growth retardation, which may develop as time goes on, the pregnancy itself, and can affect the postnatal surgical outcome. Therefore, it is also necessary to carefully assess any associated anomalies, as we mentioned at the beginning, due to the various syndromes. First and foremost, vectorial, which can be associated with esophageal atresia. In our case, the fetus was completely healthy. There were therefore no other anomalies detectable by ultrasound. Naturally, it is important to undergo genetic counseling in order to consider a possible fetal karyotype analysis, especially to rule out associations with aneuploidies such as trisomy 18 and 21 in particular. Furthermore, it is important to follow up with pediatric surgical consultation. Thank you. This is because, of course, the crucial postnatal outcome significantly depends upon the timely and effective intervention of the pediatric surgeon and is naturally also profoundly influenced by any existing growth retardation and any additional, potentially significant factors that may be detected during subsequent detailed ultrasounds. Delivery should take place in a tertiary care facility because surgical treatment is performed promptly and requires appropriate intensive and nutritional therapy until the operation. Thank you all for your attention.